I'm Kevin Rooney, a consultant in anaesthetics and intensive care medicine at the Royal Alexandra Hospital in Paisley. And I'm here today to share some learning with you about sepsis in the pre-hospital setting. So how big a problem is sepsis? Well, according to the WHO, sepsis affects 30 million people a year. To put that in perspective, there are 30 million dots on the infograph that you see in front of you. But I'm a simple guy, and I actually find that a bit difficult to understand. So how many people with sepsis are affected on a daily basis? And again, according to the WHO, that's 82,191 patients a day develop sepsis. Put that in greater perspective, that's equivalent of 145 A380s every single day, people getting sepsis. But what does sepsis do to you? Well, unfortunately, several people die from sepsis. And again, to put that in perspective, that's around 16,438 patients dying from sepsis every single day. Or another way of looking at it is 29 of these Airbus A380s falling out the sky today, tomorrow, the next day. It's relentless. We're all used to dealing with patients with cancer, and actually sepsis kills more people than lung cancer. It kills more people than breast and colon cancer combined. And the chances are that if you do have sepsis, or you do have cancer, you die from sepsis. But again, sepsis doesn't just affect medical patients. In the last triennial report, that actually sepsis was responsible for a quarter of all maternal deaths. And actually, 1 in 10 of those deaths was related to flu. When I trained in medicine, we used to be told to beware of pulmonary embolism and myocardial infarction in the post-operative period. But nowadays, the commonest post-operative complication is sepsis and septic shock, with higher mortalities than pulmonary embolism and myocardial infarction. But there isn't just the mortality related to sepsis, there's the lingering consequences and the hidden public health disaster of sepsis. In the United States, they were studying 27,000 older people looking at their physical and neurocognitive performance. And having a look at those patients who had sepsis found out that if they had sepsis, they had a 3-fold greater incidence of moderate to severe cognitive decline, increasing from 6% to just under 17%. So what is sepsis? Well, sepsis was defined initially in 1991, in 2001, and again in 2016. And sepsis is more than just infection. And it is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. How do we define organ dysfunction? Well, that can be identified as an acute change in your total SOFA score of more than or equal to 2 points. And I'll talk about SOFA in the next slide. But to put it into perspective, if you have a SOFA score of greater than or equal to 2, you've got an overall mortality risk of around 10% in a general hospital patient with suspected infection. So what is the SOFA score, or the SOFA criteria? SOFA stands for Sequential Organ Failure Assessment Score, and it scores for 6 parameters between 0 and 4 to include respiration, coagulation, liver, cardiovascular, central nervous system and renal, and you score from 0 to 4 for all of these parameters. Obviously in the pre-hospital setting you're going to be unable to score for all of them, but there are certain elements of the SOFA score, namely an orbital conscious level, a GCS of 10 to 12, being an inability to pass urine for more than 24 hours, and actually being very jaundiced, which would make you think that this patient has organ dysfunction, which may be due to sepsis. The more severe end of the spectrum of sepsis is septic shock, and that's a subset of sepsis in which the underlying circulatory and cellular or metabolic abnormalities are profound enough to increase mortality. And with septic shock, you have mortality in excess of 40%. That's quite difficult definition to give, so what we really need is a clinical construct, a clinical definition. And by that, we need to have septic shock, you need to have sepsis, so So you need to have organ dysfunction and persistent hypotension requiring vasopressors to keep your mean arterial pressure greater than 65 and a serum lactate of greater than or equal to 2, despite fluid resuscitation. So without the inability to deliver vasopressors in the pre-hospital setting for a paramedic on their own and inability to sometimes measure lactate, it will be difficult to diagnose septic shock in the pre-hospital setting. So who's at risk? Who should you consider sepsis in? Well, as you've seen already, sepsis can affect anyone of any age, of any background, and any social status. And it can develop after an injury or even a minor infection. But there are some members of the population that are more vulnerable. Those at risk of sepsis include those with a medical condition or those receiving treatment that weakens their immune system. So by that, I mean things like post-chemotherapy, neutropenia, people with indwelling catheters, people with other indwelling devices, people who are already in hospital with a serious illness, and the extremes of ages like the very young and the very old. But also people are at risk if they've just had surgery or have wounds as a result of an accident. So what are the most common sources of sepsis? Well, the most common course I see as an intensive care doctor is pneumonia, followed by intra-abdominal infections and urinary tract infections. But you can also see catheter-related infections from urinary catheters, from the long-term Hickman lines. You can see skin and soft tissue infections and also central nervous system infections. Sepsis is a complicated disease, and I'm not going to dwell on the pathophysiology. But what happens is the pathogen, be it that a virus, a bacteria, enters the skin. Okay? As a result, your immune system activates. You get a release of cytokines and cytotoxins, and they cause vasodilatation, so your blood vessels dilate. You then get a loss of endothelial integrity, you get increased permeability of the endothelium, and actually you get tissue edema. Your mitochondria no longer work, and you get activation of the coagulation cascade. Both the inflammatory and the organ dysfunction of sepsis create an absolute and a relative hypovolemia. So because you vasodilate, you've got a greater circulating capacity for fluid, but you lose fluid through the tissue edema. You get reduced myocardial contractility, and you also get impaired oxygen delivery. Organ failure from sepsis can affect lots of different things, from the lungs, myocardial contractility, immune suppression. It can affect your bone marrow and get disuse atrophy of the muscles. It can affect lots of different things, as well as acute kidney injury and an ischemic hepatitis. Back in 2009, the Scottish Trauma Audit Group audited the incidence of sepsis in hospitals in Scotland. And over a course of 3 months in the summer, they looked for people who had signs of sepsis within their first 48 hours of admission to hospital. And at that time, they said that accounted for around about 2% of emergency admissions, which is equivalent of around about 5,000 patients a year, and actually which is 5,000 patients over the 3 months, and the equivalent of about 21,000 patients over the course of the year. With the STAG report, we found out in those patients with sepsis, only 71% of those patients had an early warning score completed. 34% of them had severe sepsis, which was the old definition of sepsis. So they had a mortality of around about 10 to 30%. Only 21% of the patients got blood cultures taken. Only 32% of the patients got IV antibiotics within the hour. And only 70% of the patients had IV fluids appropriately. So depending on how you looked at it back in 2009, the defect rate for sepsis in Scotland was anywhere between 18 and 74%. And what you have to bear in mind is the incidence of sepsis has increased significantly since 2009 due to greater awareness by clinicians, but also due to the Scottish Government's sepsis awareness campaigns with the public over the course of the last 2 years. So I don't know about you, but I've got an ideal life journey. I was born, learned to crawl, learned to walk, I met my wife, and I've had 2 lovely children. And over time I will mature, I'll hopefully have grandchildren and a short period of infirmity, and then I'll pass away. But unfortunately, you as well as I know as paramedics, that life isn't fair. Quite often at any points across this journey, life can be interrupted. And what we want to do is we want to prevent any minor infection from becoming sepsis, septic shock, multi-organ failure and death. And to do that, we need to focus on what I call the 4 R's of the deteriorating patient. We need to recognise the patient, we need to resuscitate them, we need to review them, and we need to refer them. So one of the greatest challenges with sepsis is that it cuts across every specialty and every discipline, okay? And there is no pattern recognition. So you know, if I tell you that I've got chest pain radiating to my left arm, my jaw, I'm sweating, I'm nauseous, I'm having an ACS. If I tell you my face is drooping, my speech is slurred, and my left arm doesn't work, you're saying I'm maybe having a stroke. You're going to treat that with a medical emergency. But the signs and symptoms of sepsis are very vague and non-specific. Cough, headache, fever, sore throat, nausea and vomiting, diarrhea, myalgia. These could be easily mistaken for a hangover when I was at university. One of the other things that the challenge with sepsis historically was we didn't talk about it. Those of you who've seen the Harry Potter films will be aware that used to talk about Voldemort, they used to talk about he who must not be named. As clinicians in the hospital, we didn't really used to write sepsis in the case notes. We wrote pneumonia, lower respiratory tract infection. It's only over the course of the last 5 years with the Scottish Government sepsis campaign did we actually start diagnosing it with greater incidence. So there is this lack of pattern recognition with sepsis. And actually what we found out as part of the STAG report is some of the classical signs or symptoms that we expected to be there weren't all there. So for example, having a low systolic blood pressure was only present in 30% of the cases. Having an abnormally high or abnormally low temperature is only present in about 40% of the cases. And having a very high respiratory rate was only present in around 75% of the cases. So some of the cardinal signs and symptoms aren't always there. So we need to get a way we can recognise a patient with sepsis. Well, one night I was surfing the net and I saw a picture of this gentleman who had handily his psycho tattooed across his forehead. And I thought, wouldn't it be convenient if patients had their diagnosis tattooed on their forehead? Like this lady here with the COPD, but realistically that's not going to happen. So we need to make it another way to make it easy for healthcare professionals to recognise a deteriorating patient and to recognise one with sepsis. And that is the National Early Warning Scoring System, which is a score for 6 parameters and a further score for being in oxygen or not, that, where you get a range from 0 to 3, which will give you a total score of 20. You've been using the National Early Warning Scoring System within the pre-hospital setting for years now, and there's good evidence base as why we should be using the National Early Warning Scoring System. Some of you may be aware of the Q-SOFA criteria which came with the latest sepsis definitions, where they said that you should screen someone for sepsis if they have 2 or the 3 Q-SOFA criteria, which is altered mental status, respiratory rate greater than 22, and a systolic blood pressure less than 100. But as you can see now from the slide, that actually if you have 2 of the 3 SOFA criteria, your NEWS score could be anything from 4 to 9. So is NEWS any better than Q-SOFA? Well, we believe yes. We know that NEWS has a greater ability to discriminate patients at risk of the combined outcomes of cardiac arrest or unanticipated ICU admission with 24 hours of an elevated NEWS value than the other 33 early warning scoring systems out there. We know through the Scottish Trauma Audit Group that actually NEWS works in the emergency department in addition to the Manchester triage system. And last but not least, some of the research that I performed along with Paul Gowans from the ambulance service has validated that NEWS works in the pre-hospital setting. So no matter how you look at it, an elevated NEWS is associated with increased levels of an adverse outcome, be it in the pre-hospital setting or the hospital setting. We also know that in patients outside the ICU, that NEWS is better than a modified early warning scoring system, is better than Q-SOFA, and is better than SIRS with regards to mortality and/or ICU admission. Other research which was performed with the ambulance service has shown that there's a superior performance of NEWS compared to Q-SOFA in predicting adverse outcomes in the pre-hospital setting for patients with and without sepsis. So you know as well as I know that you're about to shortly transition to using NEWS 2. So why was there a need to move from NEWS to NEWS 2? Well, NEWS was designed by the Royal College of Physicians of London, and what they did was they took on the feedback from the user experience, so from clinicians within the hospital and in the pre-hospital setting. And they also included some peer-reviewed research publications like the ones performed with the ambulance service. But what they wanted to do with NEWS 2 was to highlight that a NEWS score of greater than or equal to 5 is a key threshold for an urgent clinical alert and response. They wanted a tool that allowed them to better identify those with sepsis, and they wanted also a tool that would allow you to record the amount of oxygen the patient was getting as well as the saturation. Because some people will say, oh, the patient's fine, their saturation is 94%, but that patient may be in a trauma mask of 15 litres. And also what they realised was with the use of the AVPU score, those patients who had new onset confusion who are being scored as alert. And if you've got new onset confusion, you certainly aren't alert. So with the NEWS chart, which may be different than what you get at EPRF, there has been some changes. They've moved to an airway, breathing, circulation, disability exposure sequence. The ranges are displayed in the score. And also they've got a SpO2 scale too for those with COPD, because actually with those patients you should be titrating the saturations of 88 to 92%. There's an area for you to record the oxygen device you're giving and a rate of the amount of oxygen that you're delivering as well. And also with NEWS 2, that when the NEWS is greater than or equal to 5, there's a prompt to think sepsis and consider urgent transfer to hospital. To get over the problem of developing new confusion, AVPU is changed to ACVPU, and the C stands for new confusion, which may include disorientation, delirium, or any reduction in the Glasgow Coma score. And also, what the way the tool is designed is it should be used in the pre-hospital assessment of acutely ill patients by first responders, be they a paramedic, a district nurse, or a GP. So once we've identified sepsis, we need to actually treat sepsis and septic shock as a medical emergency. And the Surviving Sepsis campaign necessitates we should do 5 things to patients with sepsis. With the Scottish Government Healthcare Improvement Scotland campaign, we adapted these 5 things to make it the Sepsis 6, where we advocate giving 3 things and taking 3 things to the patient. The giving 3 things are going to deliver oxygen therapy and target the saturations to those of 94 to 96%, or if you have COPD, to saturations of 88 to 92%. We're going to give an IV antibiotic according to the formulary, and we're going to start some IV fluid resuscitation with a minimum of 500 ml and reassess up to 30 ml per kilo. Within the hospital, if the patient is still hypotensive, we will then add vasopressors. The taking 3 will be going to measure lactate, and we'll remeasure it if it's elevated, because lactate is an independent predictor of mortality. We're going to take blood cultures and consider source control. So if there's an abscess, we're going to drain it. They've got acute abdomen, we'll do a laparotomy, and we will commence accurate urine output measurement. So what can a paramedic contribute to the Sepsis 6? Well, actually they can contribute a very lot. First of all, they can deliver oxygen therapy to target saturations of 94 to 96%. 96% is all that is needed, because we know that there are problems in things like myocardial infarction patients and other disease processes where there are complications of hyperoxia. You're able to deliver crystalloid when the systolic blood pressure is less than 90 or the mean arterial pressure is less than 65. And you can do this over 500 ml over 15 minutes with 500 ml of fluid and monitor the response. You're also able to regularly assess the patient and the response to the fluid challenge and titrate up to 2 litres if the patient has persistent hypotension. Even in normal tensive patients, your JR calc now allows you to give 250 ml of fluid to patients with sepsis. And if you have a journey time to hospital of greater than an hour and you work in the remote and rural settings, you can also give cefotaxime. So let's go back to the 4 R's of the deteriorating patient. So we've talked about recognising sepsis through the use of news. We've talked about resuscitation of the patients. We're now going to talk about the review and the refer. So what I want to talk about that's really of relevance to you is who to urgently transfer. When the news is greater than or equal to 5 and positive for think sepsis, so that is, do they have an indwelling medical device? Are they immunosuppressed through steroids, through chemotherapy, through immunosuppressant drugs? Are they at the extremes of ages? Do they have a history of infection or trauma? Think this could be sepsis. In these patients, we want you to keep the on-scene time to a minimum. We want you to arrange an urgent time-critical transfer. We want you to provide a pre-alert and a news score to the receiving hospital and tell us that the patient has suspected sepsis, and provide a safe handover using SPAR and a news score on arrival at the ED. There are some caveats here for you. If you have a news of 1 to 4, if they were in hospital, that would mean that they should be assessed by a nurse or a healthcare professional, and that patient would be getting a minimum of 4 to 6 early observations. So as a bare minimum, they should have professional to professional discussion. But I would certainly review that patient, and I think any patient really with an elevated news above 0 should have a low threshold for transfer to hospital. If any patient has a news of 3 in any single parameter, this is an extreme variation. And as a result, the patient necessitates early observations, maybe even more frequently, and needs urgent review and an urgent transfer to hospital. Again, with a news of 5 to 6, that's an urgent review. And if the news is above greater than or equal to 7, they need emergency assessment by a team with critical care competencies and may require ICU or HDU. So in essence, if the news is greater than 0, you really have to have a reason why you shouldn't be admitting that patient to hospital. So in summary, I hope that I've shared with you that sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. That organ dysfunction can be identified as acute change in your SOFA score, and that septic shock is a subset of those with sepsis who have abnormalities that are profound enough to increase the mortality to around 40%. Please use news to recognise those patients with infection who are at an increased risk of an adverse outcome. And early recognition, treatment and transfer to hospital is key to the reliable rescue of any deteriorating patient, but especially one with sepsis. I'd like to thank you for your time.